Antenatal steroids have an interesting history, though in the early 1970s we had clear evidence from Dr. Liggins and Hovey's study that it's very effective to reduce RDS in preterm babies. It's widespread use took another 15 to 20 years. And this delay is the main reason why the Cochrane neonatal group was set up to make evidence-based medicine more widely available and to start implementing such research evidence fairly quickly. If you look at the symbol of the Cochrane group, it's basically the forest plot for this particular meta-analysis on antenatal steroids, and the first study in that is from Dr. Liggins and Hovey. The antenatal steroids work by stimulating the release of surfactant, which is stored in the laminar bodies in the type 2 pneumocytes. It also stimulates the messenger RNA and thus helps fresh production of the surfactant by the type 2 alveolar cells. It has a stabilizing effect on the cell membranes, and it reduces the severity of lung disease. When the lung disease is less severe, there is more hemodynamic stability, and this leads to less IVH and less hypotension and complications similar to that. That is the reason we get benefit not only on RDS, but also on IVH, NEC, and other complications of prematurity. And either betamethasone or dexamethasone can be given as intramuscular injection. Some studies give dexamethasone splitting as 4 doses, while others will give 2 doses similar to betamethasone. The reason for giving this dosage is mainly because of the half-life. Typically, it's used after 24 weeks, but in some Western countries and where the outcomes of 22 weekers is increasing as well. So 22, 23 weekers is a consideration for giving steroid as well, if they have impending preterm labor. The onset of action occurs within the first few hours of the dose, but full benefit takes 24 to 48 hours. So if there is chance to give it early, when you anticipate that she's progressing, you give it. But again, you have to balance it because you cannot repeat the dose unnecessarily. And even one single repeat is controversial. Previously, in the early 90s to late 90s, there were many studies which looked at repeated antenatal steroid doses at weekly interval in twins and so on. They found that the repeated doses had side effects on the fetal brain as well as the fetal lung maturation. So it doesn't help and it may harm. So there is some consideration for a repeat course if there is impending delivery 3 weeks after the first dose and the mother is still 32 weeks and below. So where you gave the first dose of steroid, she didn't deliver, and then after 3 to 4 weeks, she is going into preterm labor still below 32 weeks. You may consider giving a repeat course, but that's only one single repeat that can be given. So the first dose should be chosen with care, when to give it and in whom to give it by the obstetrician. Keeping this in mind, they shouldn't rush to give it just because it's a twin and they reach 28 weeks or something like that. If she's in active labor and you really think she's going to deliver, you give the steroid. There is some evidence that it can be used in 34 to 36 weeks. There was an ALP study from US and some guidelines were modified. But still there is controversy whether we should really use in the babies above 34 weeks because the RDS is not that severe, and as the baby gets bigger and we have more sophisticated management in the NICUs, the outcome is good. So we don't need to give a medicine which could potentially be toxic. And in elective LSCs in term babies as well, the same ideology is coming up. So there are 2 groups. One may believe in giving it and one may believe in not giving it, because there is a study on neurodevelopmental outcome of the babies who received steroids at early gestation, but they didn't deliver preterm. They went on to deliver term. And the babies who received steroid have a poorer neurodevelopmental outcome. This could be because of the reason they received steroid in the first place, but it's not clear cut. So if you feel it's not to be given, it's fine as well. So we discussed the benefit already, reduces the severity of RDS. There is improved survival and reduced IVH as well. The illness severity and overall hemodynamic stability may contribute to the non-respiratory benefit.